I now have the pleasure of welcoming our speakers for today's session. Dr. Michael Argeny received his medical degree from Creighton University and his MPH and MSW from Boston University. He completed his preventive medicine residency at the University of Massachusetts and an addiction medicine fellowship at Wake Forest University. After serving as a clinical assistant professor at the University of Iowa, he's embarking on a new journey serving as a street medicine provider in San Francisco, where he can focus on his interest in sexual and gender minority health and addiction. He concurrently serves as faculty for the UMass PM residency and teaches courses for the UMass MPH program. We also are welcoming Dr. Andrea Silva, who's the director and co-founder of the Addiction Centers of Excellence Foundation and the Valley Streets Harm Reduction Program in Modesto, California. She holds a medical degree from St. George's University and completed her family medicine residency at Valley Consortium for Medical Education in Modesto. As chief resident, she helped start the Rainbow Clinic, which is focused on LGBTQ plus care. And Dr. Silva completed a fellowship in addiction medicine at Boston University, which earned her the Ruth Locke Scholarship for dedication to health equity. Dr. Silva is a clinical professor of addiction and family medicine at VCME, where she recently launched a street medicine and sterile syringe program. In their free time, Dr. Silva hikes with her dog, bakes, and reads avidly. So welcome and thank you so much for being here. And I will now turn the screen sharing over as well as the discussion to you all.
Thank you both really for inviting us and letting us talk about the things that we're just extremely passionate about. Today, we're of course talking about gender affirming substance use disorder treatment. This is something that I think is particularly timely over the last few years. We talk about this often, but the legislation that's really been produced over the last several years in this country, unfortunately, are not considered gender affirming treatment. And lots of physicians that we know personally are not able to even practice this medicine really due to poor policy. So we're just excited that you're here, you're listening to this talk, and hopefully take something away that can, incorporate these lessons to help really what we think of as our most marginalized patients in our community. So we'll be presenting today, and we also did want to give credit to our three other presenters that we've given this talk at a couple of other conferences as well: Mike Weiner, Barry Zevin, and Hanan Braun as well. So we have no disclosures, nothing financial or personal relationships, and also wanted to make it clear that no medications that we actually use for gender affirming therapy are actually FDA approved. So these are off-label, which we commonly do in medicine, but we wanted to make that clear. And of course, our learning objective. So what we hope for you to take away today is, being able to describe really the epidemiology of substance use among transgender and gender diverse people. Something that we're not really taught so much in medical school. So hopefully take something away. We'll also compare some strategies to sort of improve your addiction care that's really tailored to our trans and gender diverse patients. We're going to go over sort of how different substances and sort of drugs can influence outcomes for trans individuals, especially those that want gender affirming medical or surgical treatment. And lastly, my favorite thing is, of course, talking about 3 harm reduction techniques that you can incorporate into your transgender health workflow. Spoiler alert, it'll be more than needles and Narcan. So we'll definitely get to that. And without further ado, I'll pass this along.
Thanks so much, Andy. So again, I just want to reiterate and reinforce the gratitude for being here today. I don't want to assume that we're going to go over kind of a foundation of gender identity and everything so that we're all on the same page. And I don't want to assume that this is stuff that you're not already familiar with. So please bear with me if this is very basic for all of you already. So when we talk about sex assigned at birth, we're talking about when a baby is born and the doctor pulls up the baby and takes kind of a look over the body and says, okay, based on what I see here between the legs, we're going to say this is a male or a female. And so we now say assign male at birth or assign female at birth. And of course, there are also intersex babies who maybe when they come out have ambiguous genitalia, and so sometimes that's really clear from the beginning that they are intersex or that they have a disorder of sexual development, as it's also called. Other times, these are things that emerge later in life during adolescence when, secondary sex characteristics such as body hair or breasts do not develop as anticipated or develop multiple at the same time. So sometimes people are diagnosed with intersex conditions at that time. However, when we talk about people's gender identity, what we're really talking about is how somebody self-identifies in the world, the way that they move or relate to our social constructs of what gender looks like. And based on that, we've come up with terms that are based on chemistry. And if any of you ever took chemistry in high school or college, you may remember these terms of when you have molecules that are either on the same side of the bond or on the opposite side of the bond. And trans people took from these terms many years ago, many years ago, to call it cisgender and transgender. And transgender now the best term out there in general, and it's used as an umbrella term to describe pretty much anybody that falls under the idea who has an experience in whatever way that their gender is not the one that they were assigned at birth. And this may not necessarily mean that they experience like a negative experience of their gender by any means, but it means that they experience that that's something that's not congruent with what we think of as male or female. And so that includes people who are non-binary or call themselves gender diverse, not just what we think of as male to female or female to male transgender in the older concept or older language. Along with that, we also have gender expression, and these are patterns of presentation like dress and grooming and voice mannerisms, behaviors that other people use to kind of automatically assign somebody, oh, you're a male person or you're a female person or you're masculine or feminine because of the way that you dress, you wear dresses and skirts and you have makeup on, so you're feminine or you're female versus, oh, he's swaggering around and he's going to the gym and benching weights. We kind of automatically ascribe that to men or masculine people. And vice versa, on the other side, we also have sexuality. And so when we talk about kind of transgender 101, we usually separate the idea of gender and of sexuality because gender is about somebody's internal concept and identity or relationship to themselves, whereas sexuality, when we talk about sexual attraction, we're talking about how somebody relates to other people or whom they're attracted to or whom they want or don't want to either romantically or sexually interact with. And this also includes a broad and growing list of identities these days. So, over the last 10 years, especially, we have definitely exploded beyond the very traditional ideas of gay, lesbian, bisexual to also now including pansexual and queer, asexual, aromantic, same-gender loving, and of course, your classic straight. And then sexual orientation are often those labels that we just used. And I do want to note that just because I use lesbian or queer or whatever one way when I'm talking about it doesn't necessarily mean that the next person isn't going to be using those labels exactly the same way. So it's always great if you have that space to be able to engage in discussions with people about what exactly that means to ask. So for example, there are many cisgender men, so men who were born and assigned men at birth who date transgender women and they think of themselves as straight. but that doesn't necessarily tell you about the kind of relationship that they're having, or even potentially the kind of sexual behavior that they're engaging in. And that brings us to the next term, that sexual behavior that we often talk about or look at in literature. We don't necessarily do research on an identity. We do research or talk about risks that are associated with a behavior. So men who have sex with men, women who have sex with women, these describe the kind of sexual partners or act as a surrogate for sexual orientation sometimes, but they're not necessarily inclusive of various identities or various sexual practices. As I just talked about, attraction and orientation. So a cisgender man who's attracted to transgender women doesn't necessarily equate what we think of as classic straight men behavior in bed or in relationship. And even then, people who are queer or gay identified may, for whatever reason, or have attraction or be in a relationship with somebody who is opposite gender. So I just want to make it clear that both gender and sexuality are so much more fluid than the labels imply, and they don't equate each other.
And, one way to sort of echo this sort of non-binary or very much a range of expression or gender identity or who you're attracted to or emotionally attracted to is just sort of this old gender unicorn. It's something that you can pass along to other people that sort of maybe don't have the greatest understanding. But I think the most important thing to take away here is that, of course, gender is non-binary, and that's what makes it so fun and exciting. Another way to really look at gender is also through the gender galaxy. This was a really neat way to think, we're not just talking about trans people, or we're not just talking about people who are genderqueer, but, giving that space where someone can feel safe enough to really identify how they feel and how they want to present in the world. You can see it's a sort of beautiful galaxy of diversity, which we, really appreciate.
And I think something to also think about is, for me, especially as a white person, I experience gender in a very specific way, and there's so many other ways of conceiving gender in other cultures that we don't even do a great job at representing in our work today. And part of that is also the research and the epidemiology that we do know about also doesn't necessarily represent a lot of those diverse genders that are coexist in different cultures and within our white American culture here today. And unfortunately, trans health is kind of it's growing. It's getting a lot more attention than it used to, but still the research and the evidence that we know about it, especially for substance use, is not that common. So what we can tell you about today is slowly growing, but relatively basic.
Yeah.
And it's very heterogeneous, but one of the bigger studies that just came out, I think in 2021, I've forgotten, basically shows that across the board for both trans masculine and trans feminine patients, every single substance is used at a higher frequency than for cisgender peers. And I mean, we're talking about substantially higher. And you may already have seen this in your work when you've had trans patients come in, and it may be kind of like, okay, yeah, that's not surprising, but I want you to know that it is definitely backed up by the evidence out there. So just as an example here, you can see that trans individuals have 4 times the higher prevalence of cocaine substance use disorder and 3 times higher the prevalence of opioid use disorder compared to their peers. And this is particularly worse for trans feminine patients, even compared to trans masculine patients. And we can certainly take a guess at why that is when we think about the fact that they're more likely to be harassed by police, they're more likely to have incarceration history, they're more likely to have housing instability or insecurity, all of these different things. And you'll you also have to think about who are the people that are even able to participate in these studies. And if that's true for these people who participate, that may be even more compounded in people who are unable to participate in these studies. And there are other studies that also support, unfortunately, the evidence that substance use is a problem and seems to be in higher frequency among transgender people. So very briefly, older studies out of 2015 and 2017 also said that there were higher rates of substance use treatment history among adults who are transgender than cisgender. And then there were also they found many things that were associated with that, like I had just gone over, including PTSD, sex work, intimate partner violence, etc. And unfortunately, we also see some smaller studies and smaller evidence of substance use being more frequent among our transgender youth as well. And that's especially concerning in the wake of all of the anti-transgender legislation that we've had. We know from work in the LGBTQ community that family belonging and school safety and school policies are strongly associated with transgender and queer youth mental wellness. And with the constant onslaught, even if people aren't necessarily experiencing direct assault on their well-being, they're definitely feeling the effects of the political climate, and this might drive increases in substance use, unfortunately. And as it comes down to it, over and over again, we know that healthcare providers and treatment providers who don't understand or don't have a background in providing gender-affirming care does contribute to health disparities among our trans communities.
And thankfully, we do things like this talk here, to really promote safety and sort of well-being for our patients who are marginalized. So the question that comes up over and over is, well, how do you create a safer and inclusive clinical space? How do you make it so that we can start breaking down these harms that the medical system has caused to gender diverse patients? It can be actually quite simple. So in this next slide here, we'll look at sort of setting the environment. So something that we have done in various clinics in Boston Medical Center, we had an outpatient addiction clinic. We decided to make it very sort of gender affirming. And what did that look like? Well, first and foremost, what you can do and with zero cost is really train staff. There are free resources. UCSF has an excellent one to train your staff. Cultural humility. This is something that I think is thrown around a lot. The most important thing when it comes to cultural humility is really looking at your own implicit biases. This, unfortunately, we're not just talking with gender diverse patients, but of course, those that are sort of unhoused or those that are in a racial minority, you start to compound these social determinants of health, and unfortunately, they just cause troubles for patients. So one of the best things that we can do is really look in ourselves and wonder, are we treating patients differently for a certain reason? And why would that be? One thing that can be somewhat easy, though it depends on sort of your clinic space and your managers, is converting your bathrooms to gender neutral bathrooms. That can be a very, very easy change and quite affirming and welcoming to patients. Another thing that's been successful is starting a gender closet. So this is actually, of course, what our clinic turned into, which was really exciting and felt quite safe for me and a lot of our patients that came in. So one thing that we did talk about is a gender closet. I'll get to that a little bit more on the next slide. And really just having supportive reading material in the clinic space. There are lots of this available in our Rainbow Clinic here in the Central Valley of California, which is actually quite rural, quite conservative, but simply switching out sort of your tobacco use materials to ones that, have affirming pictures. So instead of having, maybe your typical straight cis people on the cover, it would be a really nice thing to maybe incorporate something that's a little bit more gender diverse. Something that's extremely important for us as well when you're setting the environment, one, because it's important to collect data so that we know that patients are maybe not getting the care that they need. So apart from getting data, this two-step method, when you're doing intake for patients, asking their gender identity or their pronouns, as well as asking their sex assigned at birth, that can be quite affirming. That is important enough to ask in a clinical visit can be really, really helpful to sort of set that stage and create a safe place. So again, always have some space that is open for people to self-identify. You're never going to always have everyone checking off certain boxes. So make sure you always have something that's sort of a comment box or something that is open-ended so that people can really self-disclose how they feel truly. I talked about this gender closet briefly. What I wanted to mention is this is something that can easily be done and is quite fun. I think we're always trying to increase our fun in medicine. So I've done this at a couple of clinics, which is just taking a very small area of your clinic, maybe just a drawer and a file cabinet, but having these on-hand items to really improve the quality of life for our gender diverse patients, especially those that are experiencing gender dysphoria. These can be easy. This can be really simple. We actually just had staff in clinic donate unused makeup. I don't really wear a lot of makeup, but I learned that there's a lot of these sort of makeup subscriptions. Everyone's getting free samples left and right. We collected all of those and we're able to really provide these great little makeup bags for some of our trans feminine patients. Chest binders, feminine shapewear, having tucking or packing accessories, having things available so that when someone comes to your clinic and then say, my substance use disorder is really due to sort of my gender dysphoria. Is there anything we can do today? You give them a bright pink shirt, things like that can make a huge difference. These things are cheap. A lot of companies will even provide free or low cost binders and shapewear. But it's a nice time to be really creative, get maybe the clinic together and figure out what you can really do in order to make patients feel safe and open up. Because we really can't help people unless they feel comfortable in our clinic to tell us really the truth that's going on.
Just to kind of give you a idea of how we work with patients from our communities, we're going to go through a small case study throughout this presentation about providing gender-affirming substance use care. And this is actually a case from Dr. Silva here, so I will do my best to do justice and they will add as needed. So here we have a 52-year-old trans woman, so that's somebody who identifies as a woman but was assigned male at birth, and she uses she, her pronouns. And she was approached during an outreach shift from the team in Boston. And in Boston, we have a very chronic and now severely uprooted settlement in the area called Mass and Cass, just outside Boston University Medical Center. And when she was approached, she said that the main thing bothering her was gender incongruence, that she wanted to transition to being more of herself as a woman, and the hormones that she was taking were not working. She was not having the effect that she wanted to have. And she also had a concurrent medical history and medical issues of severe opioid use disorder, but had recently been started on methadone. She also had prior cocaine use disorder in remission and active methamphetamine use, tobacco dependent, cervical spine stenosis, untreated Hep C, PTSD, and the official diagnosis at the time of gender dysphoria. She did not endorse any history of cancer, pulmonary embolism, or DVTs, blood clots, in other words, which are important things to assess for. As of September 2022, the WPATH, the World, I just blanked here, basically, the World Organization on Transgender Health came out with the new Standards of Care, or SOC 8. And in the standards of care, they've actually changed some of the language to what is considered less stigmatizing. So instead of gender dysphoria, which is still used quite widely, they now call this gender incongruence and said that it has to be marked and sustained. And gender incongruence should basically meet diagnostic criteria where people need such a diagnosis on their records in order to have access to health care. And basically, the reason that there has been a shift to the word gender incongruent is that not everybody considers dysphoria of having certain gender traits or whatnot, but they just don't necessarily align with the common experiences of that gender or gender expression. And so they may have a sense of incongruence that's not necessarily negative and still want to be able to seek gender affirming care, whether that's hormones or surgery or just what we consider a social transition where maybe they don't pursue medical care, but they pursue changing their name or dressing in a different way, having a shorter or longer hair that's more aligned with a certain gender expression, and so on. We also want to ensure that if there are any physical or and mental health conditions that can negatively impact the outcome of gender affirming care, that those are also assessed and incorporated into decision making for risk and benefit for treatment options. And so, when our responsibility as transgender health providers is to assess the capacity for people to consent. So most places in the US have now moved to what's called informed consent. And unfortunately, some of this has been undone with the legislation, but we definitely have moved away from the idea many years ago that people needed to have so many years of therapy and they needed to come in and they needed to have a therapist letter and they had to be able to really demonstrate that there was no way that they could ever regret this decision before they could access hormone in particular, or even surgery sometimes. And now most places, especially for hormone treatment, have moved to a let's like any other medical condition, come in, sit down, let's talk about what you're experiencing. Does it overall meet what other people experience or the diagnostic criteria? Okay, great. Let's talk about treatment and see what we can do today. And some people are starting on hormone treatment much more rapidly than they were able to, and that has made it much more accessible for people to have gender euphoria and feel better about themselves. And we also have to assess the capacity and understand the impact that gender affirming treatment has on reproduction. So, depending on their age, the impact can be very variable. You know, if we're talking about younger trans patients who don't not necessarily even gone through all of puberty, the effects can be different versus for adults where the effect may actually be minimal. If they were to stop hormone therapy, they may still retain the ability to engage in reproductive options. So that is one other thing that we are responsible for talking about with our patients and exploring what options are, because the last thing we want to do is for somebody to say, hey, I love being trans, but I didn't realize that this was a way that I could have children later in life. Why didn't we talk about this? And we also want to talk about what does the social transition look like for these patients. And for some of them, that may be, I want to do everything overnight and I really want to be like, I was never a woman and I just want to be a man and go on and that's it. Whereas for other people, especially gender diverse patients, they may want to go at a much more slower pace. They may want to kind of tease out, wait, so, for example, one of my friends who is genderqueer, they are also in a partnership with another gender queer or non-binary person, and one of them has decided, yeah, I want a lower voice. Doesn't love the facial hair, but would live with it. Definitely likes having bulked up, like the deeper voice, likes that when they talk on the phone, they are not gendered as a woman anymore. Whereas their partner is like, I don't even not interested whatsoever in any of that. I just want the shorter hair. I'm already skinny and tall, so I'm good enough with that. So they have very different concepts of what being more masculine for them were compared to what their assigned gender at birth as female was. And of course, since we're talking about substance use here, I'm curious if people have ideas or input on how your role in substance use treatment and risk reduction intersect with what we've been talking about. If anybody has any thoughts or comments that they would like to share.
This actually, I'm going to pose maybe a more of another question instead of actually answering the question. So I'm sorry, but I'm curious if other people maybe experience. I know as someone that works in this space and lives in this space, that there, especially in Kentucky, are limited resources for clinics that are specifically affirming, and it's very challenging to know, if you're not accustomed to working with the LGBTQ population in like one of these affirming spaces, like where to even refer to within our community. So I'm wondering if you maybe have specific advice for if you don't know, let's say for some of our people, like there's an office, an affirming clinic that's in Fayette County, but many of our people work in other counties. So if you're working in other counties where there's not a known resource for LGBTQ health, how could they go about even trying to talk about this work, and what to do when they don't know of a specific clinic to refer to?
I'll jump in. One thing I would say is that for us, we started sort of this gender health clinic in a very small area of California with no resources around anywhere. And what we did was actually linked with the UCSF Transgender Health Center of Excellence. They have a warm line. You can actually pick up the phone, you can call them, you can email them. And what I would say is read as much as you can, reach out to people that are doing this work, and just start it. This is not that challenging. I think the most challenging part of gender affirming care is making someone feel safe. And so when we talk about substance use, or we talk about people that are sort of displaced and unhoused, these are very similar sort of safety precautions that we're giving to all of these patients. They're used to having adverse childhood experiences, not feeling safe, not being able to open up for various reasons, or risks of being let go in the clinic, which has happened often, and that's documented in the research. So I would say, it's not that challenging to do. Reach out to people like us on this call, or really the UCSF line was instrumental in us being able to get these very specific questions answered so that you felt more comfortable delivering this care to patients. That would be one tip I would say. So we'll move right along to our good friend here, our lovely, lovely woman. So, we continue to, let me back up and say one thing here, which is, not everybody can just enter the street and start talking to gender diverse patients and make them feel safe. What we actually did in Boston was we actually found people that were already working in this community and had them really introduce us slowly to patients that were unhoused and living on the streets of Boston. So I think that's also something, is finding other people that are doing the work and maybe having them sort of give you a warm handoff to patients. And that's what we did here to actually locate quite a number of gender diverse patients on the street of Boston. A nurse that had been doing the work for a long time already was checking on patients in their tents for overdoses and was able to introduce us to a lot. So I just wanted to make that clear, that utilizing people maybe outside of our sort of traditional healthcare providers love social workers, case managers, utilizing them. Peer support, harm reductionists can be really, really helpful. So our patient wanted to, continue telling us about her history, told us that, of course, she began hormone therapy 6 months ago in Connecticut, just before she moved to Boston. She currently was on estradiol 2 milligrams by mouth BID and Spiro. Sorry, that's my little puppy. Spiro 100 milligrams BID. She also endorsed minimal body changes. She, really wanted to have this sort of softer skin, hey, baby girl, some softer skin, some redistribution of some fat to her hips, and that she hadn't really sort of experienced yet. So her overall goals were, of course, to minimize any body hair, have a more feminine voice, and larger breasts as well. So a couple of things that I think are extremely important here. Let me make sure she's okay. She's an old dog. So a couple of things that I think are really important when you're starting sort of gender affirming hormone therapy is, thinking about what are the risks of the actual medicine. So we'll first talk about sort of our feminizing treatment, estrogens, anti-androgens, and then we'll sort of talk just briefly on some testosterone treatment. So one in particular, risk of DVT, some of these risks are compounding, which we mentioned. So if we're talking about sort of a patient that is on the street, has had, quite a bit of, say, physical trauma, maybe they're also smoking cigarettes, and maybe they're also using some IV substance use, you're going to increase your risk of sort of a clot. Now, there's been quite a bit of studies showing that estrogen, yes, can increase your risk of these clottings, but there's various different preparations that can decrease that risk, such as sort of topical formulations. The other thing that's important to remember is that a lot of our patients, say that are on the street or using substances, actually have quite a high risk of dehydration. So if you're sort of worried about starting spironolactone, which as primary care doctors or addiction specialists, a lot of us have dealt with hyperkalemia, and you want to make sure that you're sort of not adversely affecting these patients even more so. So compounding risks of dehydration, spironolactone, and then of course, a lot of patients that have injection drug use also quite commonly get placed on Bactrim, and we want to make sure that we're sort of not causing additional problems here. There can be quite a lot of information about sort of mood instability and how that can affect patients when they're starting estrogens and testosterone. And now it's not uncommon to have sort of fluctuating levels of these hormones, but I think the most important thing to remember is that as long as patients are following up with you, I'm so sorry about this little pup. As long as they're sort of following up with you, you can really address their mood instability quite commonly. Sorry about that. I think I'm going to pass it to you. I'm going to pass it to you, Doc, so I can mute myself if you want to finish this last smoking one for a second.
Of course. Yeah, this one is a great one to have in your back pocket. So if you have somebody who is a trans feminine patient and they're thinking about going on estrogen, or they're already on estrogen, and saying, hey, and somehow you find out that, hey, they're not having the changes that they would like or that she would like. Well, it turns out that cigarette smoking does impact the metabolism of estradiol estrogen. So it means that they may actually be getting rid of this estrogen in their body more quickly than they need to have that hormone in their body, and therefore that's why it's not working. So if you're trying to work with them about reducing their smoking or even stopping completely, you can talk to them about, hey, you might have better changes or ones that you're looking for if you drop the smoking. And that's just because of the way that cigarette smoking induces a certain cytochrome or P450 activity in the 1A2 and 2B6, and that is stuff you don't necessarily need to know unless you're taking an exam. But the big thing is there is definitely an interaction here, and that's one that can come up frequently and that is significant for people to know about. And that's a little different than the other one, than other substances. There are not as many direct interactions between gender affirming hormone treatment and substances, but this one is one. Back to you, Dr. Silva.
Perfect. So, I think, so we'll kind of just change gears a little bit here with testosterone regimens and really sort of masculinizing treatment. Some things to keep in mind is, again, when we're talking about our patients with substance use or substance use disorder, commonly we're talking about increased risks of sort of sexually transmitted infections, HIV, of course. So important to recognize that, adding testosterone can increase libido. Someone maybe perhaps is also using stimulants, something commonly called chemsex, sort of heightening sexual experiences, very common in the LGBT community. So sort of recognizing that testosterone in and of itself may not increase your risk of sort of HIV directly, but can it sort of increase libido, especially in someone who's using methamphetamine? Do we need to sort of have a little bit of extra care in talking about PrEP or PEP or just sort of safe sexual practices? But again, these are sort of not absolute contraindications, just really something to be, considering as you're starting these. There is some evidence that testosterone can sort of increase impulsivity, maybe even some aggression. That really seems to be most commonly in patients with an underlying bipolar disorder, some other mental health conditions that are sort of prone to impulsivity. This last point on here is that this sort of roid rage is really a myth. That's been kind of propagated in movies and the media over a long time, but really roid rage is not something that we see often, especially when we're talking about testosterone at sort of physiological doses. But keep in mind, if someone does have sort of an underlying impulsive disorder, a bipolar disorder, that could be a possibility of sort of having that little bit of mood changes. The other thing that I think is important too is knowing that some other meds that people are already prescribing or taking, but there's already something we already do in medicine. So for instance, someone who's on maybe, PDE5 inhibitors, Viagra, for instance, may interact with methamphetamine directly. You might end up having decreased blood pressures, increased blood pressures, priapism. So, being really clear that you've taken a good history on the medicines that patients are currently taking, and just as you normally would do, sort of cross-referencing any sort of contraindications, of which, again, there's very, very limited in gender-affirming hormones. And then again, is there some street medicine for hormones, testosterone, estradiol, progesterone? The question's yes. Could you increase this risk of diversion? Maybe, but so do other medicines. Antibiotics, for instance, will definitely be sold on the street, and you're always weighing the risks and the benefits of having a safe supply of testosterone to someone generally outweighs the risks of a very small risk of diversion. So we'll circle right back to our beautiful, beautiful patient. After meeting with her over several weeks, I do like to report that I think we increased her gender euphoria. You'll see on here we didn't, I thought we did a lot, but you'll see a lot of it is not even particularly medical. So, reviewing expected time courses of changes with patients is so critical. I can't tell you the number of times I've been in clinic and someone says, "Oh my gosh, I don't have the fat redistribution I wanted." And you say, "Oh, well, gosh, how long have you been on hormones now?" I say, "Oh, it's been about 4 weeks." You say, okay, we know you're excited, but really being clear in your mind, what are the time courses of these bodily changes? What can you give as far as an expectation to patients? And all of this is online. These things are very easy to find. Baseline that we did on her, we actually did some phlebotomy in the field, collected blood for labs, hadn't had any sort of hormones or infectious disease workup done in a long time. So we drew those for her as well. Again, very basic, total testosterone, estradiol, BMP, and some STI testing. We refilled some meds. And then, one of her biggest concerns was, I really want my voice to be lower or to be more feminine. How can I do that, right? And a lot of people say, well, we'll refer you to, this tertiary care center. We'll go see a specialist. There are free online voice training videos that work wonderfully, and patients tell me about constantly. So get creative. How are some things that you can really improve gender euphoria? Real time. Right? Real time, giving someone that access to that free online video. She wanted a breast surgery consult, so we were able to sort of refer her for that. And very commonly in our gender diverse population, we have increased risk, and we talked about mental health concerns, but really suicidality. So really important to sort of address that. We gave our patient these emergency hotline numbers, sort of connect with local people, also suicide hotline numbers, specifically catered for LGBT people and trans people too. And we were able to sort of connect her with her primary care doctor. And then, of course, what we do, because we like to be a comprehensive sort of medical provider, we made sure that she had a new glass pipe since she was using methamphetamine, needles just in case for some IV drug use, some work. So those are going to be things, of course, like tourniquets, alcohol swabs, cookers, condoms, lubricant, all kinds of things. And of course, naloxone. Although she's on methadone, we're concerned about sort of stimulants being contaminated with fentanyl and causing this increased risk of stimulant-related overdose deaths. And lastly, we were able to give her a little makeup bag, toiletries, hair accessories, gave her a pronouns lapel pin, and you can't believe the change in just a week of seeing this patient, when we really didn't do a whole lot of what you would consider sort of traditional medical care. It's listening, making her feel safe and heard. And I felt that this was quite a success story. So, I think one thing that can happen, it happens often when we're talking about gender affirming hormones and surgery specifically, is do patients need to be sober in order to give them gender affirming therapy? Oh, I get this question all the time. Someone's on methamphetamine, how are they going to follow up for their appointments? They're using fentanyl. How are they going to make it to their pre-op appointment? The reality is that if you start or continue treatment for gender incongruence, that is an absolute essential step to someone recovering from their substance use. So, as much as we want people, or some people, some people don't want our patients to use substances, and that's okay. But the reality is that if you can get someone to feel like themselves in their own body, a lot of their dysphoria, a lot of their sort of mental health conditions, suicidality, and substance use can decrease. This is anecdotal. I see this all the time. I see patients in our gender health clinic every week, and this is very common. The reason that I use alcohol is because of my gender incongruence and dysphoria. So it's incredible how, there's so much strong evidence for improving overall mental health, decreased suicidality with gender affirming hormone therapy. There's not a lot of medicine out there that is going to give you such a bang for your buck and feel like you're really saving lives in that moment. So don't let substance use or substance use disorder, even if it's untreated, don't let that necessarily stop you from getting people their gender affirming treatment. But, as we talked about before, make sure people understand the realistic risks and complications, and make sure that they know their reproductive rights, make sure that they know exactly what they're getting themselves into. We'll pass that along.
I think also just piggybacking on what we were just saying is also by offering access to gender affirming care for your patient who has substance use disorder or just ongoing substance use, it's just the ability to keep them engaged in care. So, like Dr. Silva said, when they get to be themselves, they're going to do better, but it's also making space for them to be in your clinic or in your treatment center, even if you don't necessarily have those services directly on site. By keeping doors open and advocating for all the pieces and identities that your patients have, you're more likely to keep them engaged in your treatment plan that you've developed with them.
Mm-hmm.
Ever so briefly, I just wanted to go over also substance use with sexually transmitted infection and HIV, because these are often co-occurring conditions that we see among our LGBTQ patients. And in particular, thing to know about methamphetamine use, and I bring this up because I think oftentimes there's a perception that where people who are who use methamphetamine are participating in riskier behaviors, and therefore that's why they're dealing with the consequences. And so, especially in our queer community, we know that um, sexual and gender minority men who have HIV and who have been diagnosed with new HIV in the past year, a third of them were persistently using methamphetamine. However, we have also come to find out that methamphetamine impacts how treatment goes and why they even got HIV in the first place. So, things to be concerned about is if they're still using methamphetamine. So, this is also important for our trans feminine patients because they are at the most high risk for acquiring HIV. They're likely to have a slower response to HIV treatment if they continue to use stimulants. And they're also more likely to have a continued inflammatory response despite HIV treatment because of the methamphetamine itself seems to induce an inflammatory state in the body, and that can have long-term consequences on vascular disease and other things. It also increases HIV replication in the body, so they're more likely to have lower levels of ongoing HIV virus circulating in the body even on treatment. However, it also is more likely to cause somebody to acquire HIV because there is potentially decreased anti-HIV activity in the mucosa. And so these are people that when they're using methamphetamine, it changes the way that the body is. And even in a single episode, the risk, so to speak, for, let's say they're having receptive anal sex, that's the highest risk behavior for HIV acquisition, there may be changes induced by methamphetamine that increase the likelihood that an HIV penetration in the mucosa actually becomes an infection. And that is not because of bad choices or decision making around behavior. It's literally a consequence of the methamphetamine use. And when I have shared this with patients, they have told me how incredibly powerful that was to know because they've been carrying around the stigma of I got HIV because I made stupid mistakes or because I'm a druggie or I'm addict. They have literally told me those things, and they have said, thank you for giving me that knowledge because now I can think about how there is an actual biological relationship between these things, and it's not just because of my decision making.
Mhm.
There's also been some work done on PrEP and gender affirming hormone treatment. And just so you know, PrEP is pre-exposure prophylaxis for HIV. So many studies have particularly looked at transgender women. We do have studies that have also looked at the effectiveness of HIV medication for preventing HIV acquisition in transgender men or transmasculine patients, but not to the same extent. There is some evidence that people who are taking estrogen may have slightly lower levels of the HIV medication tenofovir in their bloodstream, and it did not seem to be associated with actual ineffective treatment of the HIV PrEP, and therefore they should not be concerned that they're not protected against HIV. So please, if you have ability or access to provide referrals for PrEP in your work, please continue advocating for this and letting your trans patient know that yes, it absolutely will still work for you, regardless of your status on hormone treatment. And regardless of so either which way, the hormone treatment will not necessarily negatively impact the PrEP effectiveness, and the PrEP will definitely not impact your hormone treatment. In the future, as we keep going along, there are going to be other things that can come along. We're starting to see some use of doxycycline is an antibiotic both before and after sexual activity. It's a way to reduce the community burden of infections like chlamydia and syphilis and gonorrhea, and that's being used more widely. And we also now have a long-acting injectable for PrEP. So instead of taking the pill every day, there's now been a switch to getting an injection every 2 months. And we don't have a lot of evidence yet for that for people who are injecting drugs, but we hope to have that in the future as a way to also reduce the risk of HIV among our patients who are injecting.
So the next thing, we sort of did talk about this a bit, but, I did want to be really focused here when we're talking about substance use and gender affirming surgery in particular. And I think the reason it's so important to bring it up is that we on our side as, gender affirming addiction specialists, we can do everything in our power to set the stage, have a safe space, read the latest WPATH guidelines, get patients to surgery. But the reality is that the surgeon and the surgical team really has their own expectations and concerns as well. And a lot of those are quite valid. And so we want to make sure that sort of this whole healthcare team is on the same page and the patient feels supported. And I think us as gender I hate to use the word expert, but gender doctors and addiction specialists, we can really do a lot to advocate for our patients who want to get this gender affirming surgery. So some concerns that we hear quite often, especially when it comes to substance use disorder and getting gender affirming surgery, is really sort of this risk of this poor understanding of outcomes and realistic expectations. These are complex surgeries. The risks and the complications can be absolutely catastrophic. The last thing that you want is a patient to sort of go into this thinking that, well, I'm using methamphetamine every day, but I'll be fine. That's the last thing that you want. You really want to make sure that even if it takes multiple short visits over several weeks to make sure that the patient understands these outcomes, understands that, what are the realistic expectations here? What are the risks of continuing to use methamphetamine before surgery? Really making sure that the patient has the capacity to make these decisions, while at the same time trying to keep our barriers very low to care. Another common thing that we hear often from surgical teams is that there's sort of this risk of poor adherence to follow-up. And that is very reasonable. We think about patients that are even sort of unhoused. How are they going to sort of adhere to these wound changes and who's going to be their peer support? So really thinking about what is this post-operative care going to look like, making sure that there's a support team around them. There's some data around, especially stimulant use and anesthesia complications. So again, making sure that patients know that, maybe saying something like, well, maybe we can cut back for 2 weeks before surgery. You don't want to give people sort of ultimatums, and you don't want to say the only way you're going to get surgery is if you're sober for a year. We see that all the time, but you do want to work with patients to sort of get them in the most optimal state before their surgery. And if that means cutting back tobacco use for 6 weeks, any positive change is going to be helpful for the patient. Risk of poor healing, that is extremely common when we think about stimulant use, and especially when we think about tobacco use. So again, employing all of your fun, techniques around tobacco cessation can be really particularly helpful. And starting as early as possible and having these conversations will only make it easier when it comes time for patients to actually see that surgical team. Risk of infection is common. And as I mentioned, these catastrophic outcomes that can happen with any surgery, but can be particularly devastating with gender affirming surgery. And so having these conversations, building that safe space, being able to have, a back and forth conversation about what really is expected. A couple of other things, we really sort of talked about this, but, we don't have a lot of data specifically in gender diverse patients with substance use and what their complications and risks of surgery are. A lot of our data is actually sort of anecdotal. A lot has been borrowed from sort of similar surgeries, maybe in cisgendered individuals. Of course, what we do know overall, and I mentioned, is that the the effects of smoking and nicotine on the microvasculature is really better documented in cisgendered people. It really makes sense this would translate to gender diverse people. Again, we talked about sort of anesthesia here. And I think the most important thing that we really need to talk about is, why are we concerned? A lot of patients, when we say, we don't want you to use methamphetamine, a lot of patients assume that that's sort of coming from this moral idea that drugs are bad. So just being really clear with patients, it'd be great if we could cut back your methamphetamine use, maybe stop it. And these are the reasons why. It's really important for people to make these educated decisions for themselves with all of the information actually presented. So again, get informed consent, give these expectations, have meetings. And I can't emphasize enough, having peer support, whether that's just a friend, maybe that's someone at your local Pride Center, having someone there to really walk with the patient and be there as a resource is just, I really can't emphasize how important that is for patients. So we'll mention here, because this is, I think we hear harm reduction now more and more in the media, which is exciting, but also has unfortunately caused some grief. It's become sort of this like loaded word, but I want to be really clear here that harm reduction is something that a lot of us are already doing in medicine. Right? Harm reduction is more than needles and Narcan. Harm reduction is a movement for social justice. Right? This is exactly what we're already doing with gender affirming care. Harm reduction and gender affirming care share a lot of similar tenets of healthcare: autonomy, self-definition, informed consent, dignity, respect, meeting people where they are. This is exactly what we want to do in marginalized communities. And it's extremely important sort of when we talk about gender affirming care. And again, I know nobody wants to sort of point fingers at ourselves and say we're at fault here. But the reality is that we as healthcare professionals, we need to recognize that the harms of this medical system that we've been working in have created a lot of harm for people that are gender diverse. And we need to just stand together and really commit to mitigating these harms. This is in people with substance use disorder, substance use, gender affirming care. And when you lump them all together, you can only imagine how much these harms have caused people in our community. So commit to it, read about harm reduction principles. And I think a lot of people will find that this is something that they're already behind or can get behind. Go ahead.
As part of our harm reduction effort, obviously we talk about syringes for people who are injecting drugs, as in, opioids and methamphetamine and whatnot. But there are also syringe service programs for transgender people. So we've talked about how people do source hormones from the street, or they source them from overseas. And so as a way to respond to that, different places have come up with their own syringe service program for transgender patients so that they also can inject their hormone in a safer manner than perhaps what they've had access to in the past. So these are, if you go online and you Google a couple of places, or if you Google for transgender syringe service programs, you will find them, and you'll be able to offer those to your patients. Some of them do offer it by mail order, so it's not necessarily just for local community, but they can be shipped across the state or across borders as needed. Mm-hmm. And when we talk about gender affirming addiction medicine, if you put that into Google, you don't get any hits. This is not a thing of integrating transgender health and substance use care. It's not a thing yet. It tends to be very siloed, and that's exactly why we've been so excited and honored to be able to talk to you today, because we're one of a few people trying to break down those silos and bring together the expertise in both camps. Like, you are here as such experts in substance use, risk reduction, prevention, and treatment, that for you to be able to cross that bridge and link with your local communities for trans health, or with us, or with the UCSF Center of Excellence, all of these things, that's going to really help bring us into an era where in the future we can actually talk about gender affirming addiction medicine as a thing.
I think that was already a really great thank you. But I think one thing that we always want to make sure we do is really thanking our patients for teaching us, really, and supporting us every day. They're really the heroes. They're the ones that have, been so brave and to share their experiences with us. It's sort of incredible to me when I have a patient coming in and they're 65 years old and they're finally opening up and they say, I've never felt safe before. That's also thank you so much to the patient for even being so brave to share these things. So, but really thank you guys for listening and all of the advocates out there, because we really need more allies. It's if you're too big to fail, that's what we want. We want a cohort of people that are supporting the most marginalized patients, and this is a step in that right direction. So we would love if you contact us. We are happy to share resources. We, have lots of resources on how to specifically prescribe sort of these hormones, testosterone, estradiol, and whatnot, in very easy sort of forms, and things that you can pass on to maybe your learners, residents, medical students, get them excited early on, especially if they're interested in addiction medicine. Say, well, how else can we sort of incorporate some other levels of care with these patients here to keep them engaged? So reach out to us. We would love to hear from you. And just thank you so much for this opportunity.
Thank you so much to you both for being here with us today and presenting this information and this topic. I saw that there was one question in the chat, and it was maybe partially addressed, but maybe we could explicitly address it. But I'd also just like to say that we do still have a little bit of time. So if people would like to put questions in the chat, maybe we could address them today. And if not, again, we'll be happy to address them during next week's Q&A. But I did want to at least explicitly ask this question, where a lot of the members on our call today work with clients, but are not directly with the MOUD clinic themselves, so not the provider, or that they're working in a capacity where they work in the office but aren't part of the actual team themselves. So what's a feasible first step for people working in these capacities to promote a welcoming clinic environment in their role?
Yeah, I would say, as a queer person who enters the room and is looking for a rainbow flag everywhere I go, it can be as simple as wearing a rainbow flag lapel pin. It's simple things. It's, having something that says all are welcome here on your front door. It's going up to clinic staff and saying, hey, I know I don't really work in this particular area, but I was reading about it, and I think we could maybe be a little bit more welcoming to our staff or to our patients. And it's really simple things. In our clinic, again, we sort of changed out some of our smoking pamphlets to include, 2 queer people on the front cover. So you can be an advocate for change, and they can be very, very simple. One thing that we also love to encourage our own residents, in a very similar, to really address this question, is introduce yourself with your own pronouns. It's sort of incredible how if you say, hi, I'm Dr. Andrea Silva, my pronouns are she, they, how can I address you? Man, that goes a long way. So I think doing that, maybe scribbling your own pronouns on your work ID. I mean, I don't want somebody to get fired over that, but there's very simple things that you can actually do to make people feel safe. And I think introducing yourself and identifying yourself and the pronouns that you use is such a great way to show respect, that you care, and that you're even thinking about gender diverse people in the clinic.
I think similarly along those lines, people go online and they look up your clinics, they look up your treatment center. Do you have anything on your website that affirms that says you're LGBTQ affirming? Do you have a list of providers or staff members? Are any of them also willing or openly queer, and are they willing to put that on the website and say that? Because somebody may say, I don't know if I want to go into this treatment center because I don't know if they're going to be able to take care of me. Also, another thing is if you're in a residential treatment center or a methadone clinic or something like that, Do you have a space for a gender diverse patient, or do you only have male and female bathrooms? Do you only have male and female gendered bedrooms for your clients? Do you have a way to approach that topic? Do you have a policy in place in your policy handbook that talks about what do we do if we have a transgender or gender diverse patient? How are we going to room them? How are we going to do a urine drug screen with them if we have to? So these are ways that you can start to approach that in your clinic, or just make space for what do we do if we have a patient that's not comfortable going into the men's room, but they're also not comfortable going into the women's room for whatever reason. So those are ways that you can advocate for some changes. Do you have a way that you have a staff restroom in the back where, even though that might be more work or time for you, it's maybe the safest place that your geographical location and structure offered for a non-binary patient to be able to do the urine drug test? Those kind of things, I think, are also not necessarily medical, not necessarily clinical, but definitely say to a patient, hey, there is a way to navigate the space with you. Even if it's not perfect, it is something that respects who I am.
Thank you. That was definitely, I think, many practical, tangible, and relatable solutions that anyone can be involved in. Another question that just came through are asking about recommended trainings for sober living spaces to consider.
Gosh, I don't think I know specifically for sober living training opportunities. What I would say is there is very good training for general clinic space, again through UCSF. It's a staff training. We have all of our residents and our staff take that before they rotate through the Rainbow Clinic. I don't know of anything in particular for sober living or say a residential treatment. I don't know about if you know of anything, Dr. Argeny.
No, I don't either. I think that's definitely an unexplored area. But we can certainly take a look around and see if we have access to anything kind of, through the W path and whatnot for our subsequent session.
And it's interesting. We'll definitely look that up because there are quite a number of sort of AA groups or NA groups that are very specific to sort of gender diverse or just the LGBT community. So I think we're considering this more. There are sort of sober groups just for queer people. So we will look that up to see if there is anything, because there are some services out there. I just don't know specifically for sober living. That's a really good question.
And I do want to make the note that as somebody, in Iowa, we do have a specifically LGBTQ AA group, and I would often recommend or just give a blanket statement, regardless of who the patient was, I would give them a list of the AA groups from if they were in the Iowa City area and just highlight that this is an LGBTQ one, because people may not disclose even to somebody who's an openly queer provider that they also want that. That being said, sometimes those groups are very heavily catering to a very specific part of the LGBTQ community, and so they still may not be the right fit for somebody who falls out of that group. So, for example, if a group is very heavily gay men, a young transgender woman may not feel comfortable going in and being like, okay, these are all 40, 50 plus year old gay men who drink, who have now been sober living for 15 years after the 80s of drinking. They may not relate to that space, but it's still good to know about what those resources are in your area. But we're happy to look into this more before next time.